Hi guys, it's Laura, a nurse practitioner in medical oncology, just to talk about understanding of thyroid function. And right, let's get straight into it. Trying to get the buttons to move. So today we'll just kind of look over understanding the thyroid gland, types of dysfunction, diagnosis, management, and treatment, and looking at some of the options we've got. So really the thyroid gland is a crucial component of the endocrine system. It plays a vital role in metabolism and overall health. And when we talk about the thyroid, we really need to acknowledge the parathyroid glands that sit behind, and we'll talk about the anatomy in a second. So, anatomy and physiology of the thyroid gland. The thyroid gland sits on the anterior throat, just below the larynx, and it is definitely a little organ that packs a punch. It has a big job. So we've got one thyroid gland in the body. It is butterfly shaped with two lobes on each side, connected by some tissue called the isthmus, and it is the size of a walnut. It uses iodine from the food that we ingest and combines this with amino acid tyrosine to produce the hormones triiodothyronine, T3, which is called that because of the three iodine atoms, or thyroxine, which is T4 for the four iodine atoms. Thyroid hormones influence almost nearly every tissue in the body. There is 80% of T3 is converted of T4 is converted to T3 in the tissues such as the liver and the kidneys. T4 is the storage hormone, and it's converted to T3, which is the active, more potent form, which affects the body's functions such as that metabolism, regulation, energy production, growth, and development. And it also plays a major role in controlling how your body cells use the energy from food whilst maintaining balance. It also has the thyroid gland function is metabolism, we've said, heart and digestive. Also control brain development, mood, and bone maintenance. So they've got a role in all of that function. So just to kind of touch on the parathyroid, so nearly everyone has got four parathyroid glands. Some cases, quite rare, there's more. They're the size of a grain of rice, and they sit behind the thyroid gland, and they all produce parathyroid hormone to regulate calcium in the bloodstream. And as we know, calcium is essential for blood and bones, muscle function, nerve conduction, communication, and blood clotting. It's also essential for proper function of our musculoskeletal system, cardiovascular system, and nervous systems. And it works on a negative feedback loop, which is that calcium levels in the blood fluctuate. When calcium's low, the parathyroid gland senses this and it secretes parathyroid hormone in response. This then activates the cells in your bones, the osteoclasts, to break down the bone minerals, releasing calcium from the bones into the blood to elevate that level of calcium, and also acts on the kidneys so that less calcium is filtered into the urine and stays within the bloodstream. So we've got reabsorption, but it also excretes phosphate. And a final action of parathyroid is to activate vitamin D. So it actually converts vitamin D from its less active form of the 25-hydroxyvitamin D to its more active form of 1,25-dihydroxyvitamin D, and this facilitates absorption of calcium in your intestines. And then once calcium levels in your blood are back to normal, this all slows down and regulates itself. So we do have hyperparathyroidism, which is an increased PTH secretion, and we have hypo, which is a little bit rarer. It does happen, but less common than hyper, where we have low hyperparathyroid secretion. And as I said, it's for calcium regulation, bone health, kidney function, nervous and muscular systems. And the primary causes would be within the gland itself, so like an adenoma, non-cancerous nodule, or increased secretion from like hyperplasia, enlargement of the glands, and they're overactive. and then we can have secondary problems caused by chronic disease such as renal failure. And just to really touch on signs and symptoms, this is hyper only. We have that pictograph of the signs and symptoms, but they're also on the screen. But we can have heart palpitations because of the hypercalcemic effect on heart rhythm, high blood pressure, again because of hypercalcemia, nausea and digestive issues, hair loss, mental health symptoms, depression, confusion, disorientation. And some people are actually asymptomatic and have no symptoms at all, and the condition is diagnosed through blood tests. There can be a gradual onset, and it gradually develops and worsens over time, and the severity actually depends on the symptoms that the individual person presents with. So as you see, we've got some common symptoms and then some less common symptoms here as well. So we really need to be careful of the fact that the patient can have bone and joint pain, mostly presenting a little bit like hypercalcemia, as it can happen, muscle weakness and fatigue, the kidney stones, increased thirst and urination, digestive issues, and some mental health symptoms as well. So prompt diagnosis will help prevent complications and improve patients' quality of life. So treatment, just a little bit of information on both there. I'm not going into too much detail, but patients will need ECGs because of the shortened QT interval that can happen, routine pathology to check on calcium, phosphate, parathyroid hormone, the kidney function, magnesium that can be affected, vitamin D, thyroid function tests, and some of the treatment options are there, and they can be very symptomatic, or as I've said previously, asymptomatic. So we have to be really conscious of the patients who have had a parathyroidectomy because of the risk of hypocalcemia, and they get the trousseaux or the Chov-sex symptoms, which is that tetany symptom that can happen, and there is medications that patients are given as documented in the slide above. So just to look at the function of the regulation and function of the thyroid, it is again on a negative feedback loop to maintain the hormone levels, and it's known as the hypothalamic pituitary thyroid HPT axis. And when the body needs more thyroid hormone, the hypothalamus releases TRH, that thyrotropin releasing hormone, which stimulates the anterior pituitary gland to produce and release thyroid stimulating hormone, which then acts on the thyroid gland, triggering the production and release of thyroid hormones T3 and T4. And these levels in the bloodstream provide that negative feedback to the hypothalamus and pituitary, which will then inhibit further TRH and TSH release when levels are sufficient, which then hopefully will maintain that consistent and constant level of thyroid hormones in the body. So it can be influenced by iodine availability, whether that's coming from food or supplements, that can be affected by stress and cold exposure, which can stimulate the TRH release. We can also have effect from dopamine, somatostatin, and glucocorticosteroids, which suppress TSH production. And it's just to be mindful of all of these contributing factors when patients present as well. So types. Normal TSH actually runs between 0.4 and 4 milliunits per litre. Then a free T3 measures the amount of T and T4 is the available amount of T3, T4 in the blood, which is not bound to a protein. And the total T3, T4 is the free and the bound, and it's never as much. T3 normally sits about 3.1 to 6.8 picomole per litre, and T4 normally 12 to 22 picomole per litre. Just a little bit. So hyperthyroidism, so that overactive is when your TSH is low, and then when we check TSH, we should check T3, T4, and there is some of the symptoms there on the slide. I won't go into a lot of detail, but they are there for your learning as well. So that low TSH with a high T4 can be classed as a primary hyperthyroidism, which is normally that low TSH is below 0.5, so we get that overactive thyroid gland producing large quantities of T3, T4 to then suppress the release of TSH from the pituitary gland. But we do have that elevated TSH with the T4 in the reference range or above the reference range. It's primary hyperthyroidism, and if we have that low TSH and a normal T4, we talk about subclinical hyperthyroidism. We would sometimes check antibodies, and in hyperthyroidism, we're looking at checking thyroid stimulating immunoglobulins and the thyroid receptor antibodies to support a diagnosis of Graves' disease. We can do imaging, which would be normally an ultrasound or scintigraphy of the thyroid gland, just to see what's going on with any nodules, anything as well. The common causes as there is Graves' disease, which can be nodules, which produce excess hormones, and excessive iodine intake and thyroiditis. And then we can also have ongoing complications such as heart problems, atrial fibrillation, heart failure, weakened bones, osteoporosis, and they can have a thyroid storm or thyrotoxicosis, which is a crisis. So a little bit further into the symptoms and some of the medications that can cause that as well. And I'll leave that there for you just to look at. And then we can go into hypothyroidism, which again is that underactive, where we have that quite a common disorder, unfortunately. It's insufficient hormone production. So we have a high TSH, and we always check that T3, T4 as mentioned. So if we have that elevated TSH with a low T4, we normally think of primary hypothyroidism, and then with that normal T4 can be called mild or subclinical. Mildly elevated TSH can resolve without treatment, and we normally monitor, and a lot of the guidelines say to do 2 blood tests a few weeks apart, just to see what's actually happening and what's going on. Within hypothyroidism, we would check a TPO and thyroglobulin, and that's to look at a diagnosis of Hashimoto's, to check for those autoimmune antibodies that can be circulating. Again, thyroid ultrasound or scintigraphy, and then sometimes we can do an MRI brain to check the pituitary gland in severe cases if we're worried. But common causes can be surgery, so removal of the gland, radioactive iodine treatment, radiation to the neck, then the thyroid gland if it's caught in that field, autoimmune diseases, certain medications, iodine deficiency. So the Hashimoto's thyroiditis is an autoimmune disorder. It causes attack on the gland, causing inflammation and dysfunction. And in a worst case scenario, we can have crisis with a myxedema, and then that's normally if it's an untreated or undiagnosed hypothyroidism, where the patient presents with swelling of the face, lips, eyelids, tongue, and skin, and they can present pretty unwell and progress to coma and death. So there's some of the symptoms just for your information as well, and looking at some of the medications that can be included. And in this, we need to think about, obviously, for hyper, our immune checkpoint inhibitors is drugs that we use very commonly, but also they are drugs that can cause changes in the thyroid gland, as we know, because it can affect the primary, it can affect the actual gland itself, or it can affect the pituitary as well. So we have to be very mindful. And when we're looking at patients and looking at the pathology, it would be to check the trend. Is there a trend? Is it up or down? But also then to look at what's the trend happening, because normally we will have a hyperthyroidism before we get to a hypo. So we overwork that thyroid gland before we get to the point of burning it out and having to replace what the patients need in that form of levothyroxine. And that's quite common, and also fluctuations in pathology. So it's also a really good idea, as we do very regularly, routinely, is to assess the patient and their symptoms to try and get an understanding of what's happening to them. Does it correlate with the bloods, or is there something else happening as well? So we don't put it just down to that. So diagnosis really is to understand patient symptoms, what are they presenting with, and to do that thorough patient assessment before treatment. To then look at thyroid function tests on blood tests to understand what's happening with the TSH, the T3 and the T4. Is there antibodies? Have they been tested? What does that mean? But also, where do we go with that? Who do we ask for help for, like endocrinology? And normally we would have asked for them for a little bit of input prior to this if we were worried about thyroid function, and they may be the ones saying, I think you should test this antibody. Because when we're looking at, we've got thyroid peroxidase antibodies, thyroglobulin, thyroid stimulating hormone receptor antibodies, the thyroid stimulating immunoglobulins, and there's lots of different ones that we really need to think about when we're actually looking at diagnosing a patient. We also look at our imaging, as I've mentioned previously. Are we doing ultrasounds? Did we need to do a CT? Do we need to do an MRI of the brain? Are we actually biopsying this? Do we think it's disease? And that could be disease of the thyroid itself, or it could be disease coming from the patient's original diagnosis. Is it a metastatic process that's happening as well? So the management and treatment, this is just a little cheat sheet from EVIQ, our kind of Bible of treatments for our patients, and this is taken from the immune related adverse events on thyroid dysfunction, and that is on EVQ on the website. So that's really good resource for anyone that's worried about someone's thyroid function tests and any abnormality, especially when they're receiving an immune checkpoint inhibitor. So for hypothyroidism, we have good old levothyroxine, tablets that we give the patients. We normally dose them on a daily. It normally starts before food, and an empty tummy in the morning. We look at whether it can be the brand of Aroxine, it can be thyroxine, it can be levothyroxine. And we've got a little picture of all the different colours of the tablets on the right-hand side. This is a synthetic hormone, and it's a synthetic form of T4 and absorbed in the intestine. We, as I said, on an empty tummy to aid digestion and circulation bioavailability. Half-life is 7.5 days, so in a week it's at its half-life, half of the dose, and it should be at a steady state within 6 weeks. We normally would check pathology after 4 weeks, but we sometimes check them routinely, obviously, if someone's on treatment, so we can actually have an idea of what's going on. And then again, after we change a dose, if we had to dose modify, if the patient's still on treatment, we would be doing it with treatment. That's normally 3 or 4 weeks with the immune checkpoint inhibitors, so that's within the guidelines. There are some side effects with levothyroxine, and the patients need to be educated on if they're receiving a script. Some patients will take a Monday to Friday dose and a weekend dose that's different depending on what level of thyroxine they actually need. And we can find that we need to look at any other medications, obviously drug-drug interactions and any contraindications. And we find that the white 50 microgram tablet has actually no coloured dyes in it, and it's quite better tolerated in patients. Standard treatment at the minute, I think in Australia, is levothyroxine. It depends on the brand name that's available out there in the pharmacies, and it's just adjusting the dose to actually suit the patient and to make them understand the impact of healthy lifestyle, dietary changes, and complementary therapies as well, but also that if they do start anything new, that it may impact on their thyroid function, and to look at also commencement, or well, if they're on hormone contraceptive hormones and hormone replacement, then we need to look at that because it can interact, and also that if they're unwell or any other ongoing comorbidities, there may be a requirement for just a little bit more frequent testing of the TSH just to make sure we're on the correct dose. If the patient is a little bit more frail or elderly or has angina, we'd want to be starting at a very low dose and just keeping an eye on things, and also referring them to endocrinology. Some patients will be seen by the GP as well. And then into hyperthyroidism, we have carbimazole, which is classed as an anti-hyperthyroid agent in a tablet form absorbed in the GI tract to metabolize into methimazole, excreted in the urine with a half-life of 5.5 hours, and some of the side effects are there as well. So it's actually a prodrug converted to its active form, which is methimazole, and that's absorbed, and that works by inhibiting the enzyme thyroid peroxidase, one of the antibodies that we actually check for to help with diagnosis, and that's responsible for iodination of the tyrosine residues in the thyroglobulin, another antibody. So this inhibition reduces the production of thyroid hormones T3 and T4, and it makes it quite an effective treatment for hyperthyroidism, and especially in thyroid toxicosis. We also use beta blockers because some of the patients present with palpitations, erratic or tachyarrhythmias as well. So we have to be very careful of tachycardia. So this is a non-cardioselective beta blocker. It comes in tablet form, absorbed in the gut, metabolized by the liver. Majority is excreted in the urine, and the half-life can be up to 6 hours. So we do start that quite slowly because we do know it can have an effect. And as I can see, I think I've done some spelling mistakes within my slides, so I do apologise. The other thing would be to make sure that the patient is compliant with medications and that we check in with them routinely just to see how things are going, and that they actually are well and tolerating and not having any other additional side effects caused by the medications that we're introducing to combat the side effects that they're experiencing from the change in the thyroid function. So just a little case study. I've got a 49-year-old male. He is pre-cycle 3 epi-nevo for a metastatic clear cell renal cell. He's got some new weight loss, palpitations and fatigue. And he's come into clinic for review, and his pathology shows TSH is 0.03, T3 12.7, T4 3.68. Sorry, the slide hasn't caught up with any of that. There we go. All right, so what are you thinking? So, yep, if you're thinking hyperthyroidism, well done. So hyper, treated with carbimazole and propranolol, and we actually did a scan, an ultrasound, sorry, and he had a nodule on his thyroid after scanning. So nothing actually to do with the doublet immunotherapy he was receiving, which was quite reassuring. However, he had close monitoring and some check-in phone calls to make sure that the carbimazole and the propranolol were helping and his symptoms were relieving, and we were able to monitor his thyroid and get him off treatment eventually after talking to the surgeons about removing the nodule as well. And then case study 2, so I've got a 53-year-old lady pre-cycle 6 of her adjuvant nivolumab for melanoma, and she had fatigue, weight gain and constipation. So the picture's giving it away there. So she remains working, however has to nap when she arrives home post her workday, unmotivated to exercise or do anything at the weekend. So that was her pathology, and as you probably guessed already, diagnosed with hypo. She was popped on levothyroxine. So what if she was on it already? What would you do in that case? Really have a little think. We would normally refer them to our patients like this, such as this, because it can happen, to endocrinology. So we'd ask them for their opinion. And in that case, then we'd look at, do they need some scanning done, some imaging done, and some antibodies to actually see what's happening. Has the nivolumab caused any changes, and what is going on? Why is the patient on levo? But then also looking outside the box, are they taking it appropriately? Is she taking it in the morning on an empty tummy? What dose is she on? Is it appropriate? Does she need a dose modification? Does she need to try a different dosage, obviously, but also does she need to try a different brand? Simple things. Sometimes it doesn't make any difference, but in some patients it does. And just to make sure that there's nothing else going on in her GI tract that could be affecting her absorption, and then her metabolism of the drug as well. And if she wasn't on levothyroxine, then we would start and look at starting on 75 micrograms. Normal size patient, healthy otherwise, with no other comorbidities, then definitely with the scope to change. Some people would start at 50. It just depends on the patient. We couldn't make it alter it depending on pathology. So that's just a little summary of what we do when we've got non-pregnant adults with an abnormal TSH. And it's just to look into that kind of pathway to guide us and help us with our diagnostics and where do we go next and what do we need to do, just to give us a little bit of a help. And then also just to remember that stress in the thyroid function, there is a significant impact on thyroid function due to the relationship between stress hormones and thyroid hormones. So your body experiences stress, it releases cortisol, the stress hormone, that actually activates the hypothalamic pituitary adrenal axis, which triggers the release of cortisol. And cortisol can interfere with the production and regulation of thyroid hormones. It can inhibit the release of TSH from the pituitary gland, leading to a reduced thyroid hormone production. And then it can also impair the conversion of the inactive thyroid hormone T4 to T3, which can lead to symptoms of hypothyroidism, even if the thyroid hormone levels appear normal on blood tests. So, and it can also trigger or worsen autoimmune thyroid conditions such as Hashimoto's and Graves. So we've got to be very careful of how our patients are presenting and what the symptoms are and what we do next with that information to keep them as safe as possible. Just some references. I hope you enjoyed that. Any questions, then please reach out and I'll just keep uploading and keep sending me ideas of what you would like to know. And if you've got anything, please then shoot me an email. Thanks. Take care, guys. Bye.